Thank you very much, Dr. Kachoukas, and thank you, Dr. Greep and Dr. Landsman, for the invitation to share with you our experience with Marfan syndrome and Loeys-Dietz syndrome. As you've heard earlier, both of these syndromes have a propensity to develop aortic root aneurysms and carry a risk of rupture and dissection. These, however, are not the same disease. Some people still refer to Loeys-Dietz as a form of Marfan syndrome, but they are quite distinct. The shape of the aneurysm is slightly different, and of course, Marfan syndrome is associated with mutations in the genes encoding fibrillin, where the TGF-beta receptor mutations account for Loeys-Dietz syndrome. Focusing first on Marfan syndrome, Drs. Murdoch and McKusick published a paper in 1972 in the New England Journal of Medicine showing that Marfan syndrome shortens life expectancy significantly, approximately by a third. And although this paper is widely misquoted as showing that the average survival is 32 years, 32 years actually refers to the age of death of those patients who did die within the period of follow-up. And average life expectancy in an untreated Marfan patient is in the mid-40s. It's actually low 40s for a male and late 40s for a female, but significantly shorter than the normal population, which at that point was about 70 years of age. Well, realizing that Marfan syndrome, because of the risk of ascending aortic catastrophe, shortened life expectancy, my mentor, Dr. Vincent Gott, and his associate, Dr. Victor McKusick, began a series of prophylactic aortic root replacement for Marfan syndrome patients at our institution. Beginning in 1976 and up until last year, this enrolled 444 patients at a mean age of 32 years. In this series, and in fact most surgical series of Marfan syndrome, men outnumbered women 2 to 1, although the incidence of Marfan syndrome is the same between the two genders. Children made up 13%, and the mean aortic diameter in this surgical series was 6.4 centimeters. The indications for surgery initially were a root diameter of 5.5 centimeters or less, but in the last 10 years of this 35-year series, it has fallen to approximately 5 centimeters, but operation is often done earlier than that if there is a strong family history of aortic rupture or dissection. The presence of dissection, rapid enlargement of the sinuses, or progressive aortic insufficiency in a moderate aneurysms were less frequent indications for surgery. Most of the patients had a modified Bentall procedure that all of you are familiar with and is demonstrated here, with full-thickness distal anastomoses and coronary button techniques, liberally reinforced with Teflon felt strips. We have a 20-year experience beginning in 1993 with valve-sparing procedures, which we employed mainly because of the hope of avoiding anticoagulation in the younger patients. The first 10 years were 40 patients who had the remodeling operation, but as we grew dissatisfied with the risk of annular dilatation and central AI in some of these patients, we switched in 2002, 10 years ago, to the reimplantation procedure and have used the Valsalva graft exclusively since then. That constitutes 95% of patients. But this shows the aortic root prostheses used in the entire series, 3/4 of which were Bentall procedures with mechanical valves, and approximately 1/4 had valve-sparing procedures. These are the operative results of this series, which, as I emphasize again, is largely of a prophylactic root replacement. There were 400 elective repairs with one 30-day mortality. A young child with very severe infantile Marfan syndrome, who also underwent mitral repair, had catastrophic bleeding 6 hours postoperatively and suffered a severe neurologic insult. There were 44 patients who underwent urgent repair with 2 deaths, 5% mortality. So the overall mortality in the series is 0.7%, which satisfies an important prerequisite of prophylactic surgery, that it carry a very low operative risk. The actuarial survival of this group at 25 years was 50%, which I think shows clearly a survival benefit when you remember that the average size of the aorta in these patients was 6.4 centimeters. However, if one excludes those patients who had a dissection at the time of their surgery or within the early follow-up period, survival was 70% at 25 years. The presence of dissection cut survival in half, down to about 30% at 25 years. Causes of late death were many, but rupture of the distal aorta or arrhythmias constituted the two largest groups, emphasizing again that we've moved the problem to the distal aorta and these patients need continued follow-up. The predictors of late mortality were older age, which is a trivial finding, mitral valve surgery, or preoperative dissection. And late morbidity was largely in those patients who had mechanical valves and had problems with either thromboembolism or endocarditis, although the number of patients affected with that was actually quite low. Indeed, freedom from thromboembolism at 25 years in this group with mechanical valve conduits was better than 90%, as was the freedom from endocarditis, underscoring again that a Bentall procedure with a mechanical valve is still an excellent operation with very good long-term results. The distal aorta remains a concern. Approximately 1/3 of patients needed some intervention of some sort in the distal aorta at 25 years. And if there were dissection early on, it was even higher, half. To focus specifically on the valve-sparing patients, there was one death among the 135 Marfan patients who had valve-sparing procedures. Of the patients who had a remodeling operation, 6 of them required reoperation for aortic regurgitation, so a reoperation rate of 15%. But of the 95 who've had reimplantation procedures in this last 10 years, no patient has required a reoperation. And there have been no episodes of endocarditis or thromboembolism, again fulfilling the promise of valve sparing over the mechanical valves, and only one patient who's had a permanent pacemaker. 3 late deaths were due to a type B dissection. And finally, to focus on the Loeys-Dietz syndrome, again, you've heard about this earlier today, a disease described only 5 years ago, characterized by hypertelorism, arterial tortuosity and aneurysm, and the bifid uvula. I remind you that there are 2 forms of this. Type 1 makes up about 3/4 of these patients. They have the more severe craniofacial abnormalities and the more severe aortopathy. The type 2 is a more subtle phenotype, accounts for 25%, and although they do have aortic aneurysms, they tend to be less aggressive. They also have the skin discoloration that is reminiscent of Ehlers-Danlos. The natural history of Loeys-Dietz is much more malignant than Marfan syndrome. In the initial cohort of 90 patients, the mean age at death was 26. Either surgery or death occurred in 1/3, and 2/3 of all patients who were pregnant had a life-threatening complication of either aortic or uterine rupture. The indications for this group, we believe, should be really much more aggressive than with Marfan syndrome. And we have used 4 centimeters for adults and 3 centimeters for children, though we try to delay the operation in children until the annulus is at least 18 millimeters, so that they will be left with a valve that can take them into early adulthood. We've done 47 aortic root replacements in Loeys-Dietz syndrome. The mean age was 20. The incidence, or I should say the gender distribution in root replacement for Loeys-Dietz syndrome is 1-to-1, in contradistinction to Marfan syndrome. The incidence of bicuspid valve is the same in Marfan syndrome and Loeys-Dietz, approximately 2%. And in this series, the preoperative maximum sinus diameter was 3.9 centimeters, but a Z-score of 7. Most of these patients had competent valves. 38 or 80% of these patients had valve-sparing procedures with a mean cross-clamp time of 101 minutes. And this slide is mainly to demonstrate that quite a few of these patients have associated lesions. 1/3 have a PFO. Septal defects are much more common in this than in Marfan syndrome, and the presence or PDA is there in about 10%. The results with valve-sparing procedure in Loeys-Dietz have been equally as encouraging as with Marfan syndrome. No operative or early mortality, 1 late death because of a rupture of a left subclavian artery aneurysm, 1 reoperation for pseudoaneurysm, 1 reoperation for a failed floor to sleeve because of coronary button aneurysms and dilatation at the base, and 1 reoperation for a dilated distal ascending aorta. We do think that dilatation of the very distal segment of the ascending aorta is a problem that presents much more commonly in Loeys Dietz than Marfan syndrome. But gratifyingly, no reoperations for aortic regurgitation, although 1 patient has at least moderate AR. And there have been no cases of endocarditis or thromboembolism. General principles of management are similar to Marfan syndrome, as you see here. So in summary, Marfan syndrome and Loeys Dietz syndrome are different diseases, but they share ascending aortic dissection and rupture as the most common cause of premature death. The recommended threshold for aortic root surgery is 5 centimeters for Marfan syndrome and 4 centimeters for Loeys Dietz, 3 centimeters for children. The operative risk is low, and valve-sparing procedures are applicable to most of these patients, but the reimplantation procedure is preferred. And the reintervention rate for both of these diseases is significant, so close follow-up and surveillance imaging is very important. Thank you very much.